Now, what I'm going to suggest to you is there's actually a better way to set up your structure that makes more understanding relevant to our situation. So let me get all this stuff out of here. Take that. We're going to get this going. Move all this stuff back over here. We're going to create another structure. And this is why thinking about things in a certain way is important. Add a few other new players over here. And take a quick break and bring in our new actors, both good and bad. All right, so now we're going to build another structure that's probably more relevant to us in convenient care. Again, 4 parts. We're going to start the first part, which is going to be the anatomy. The second part is going to be the source. Third part is going to be the bacteria. And the fourth part is going to be the antibiotics. All right, I'm going to clean this up a little bit over here, just because drawing the line apparently screws up this computer program. So there's urethritis. Now, the way I distinguish urethritis is that urethritis you should look at as infectious and non-infectious. I know it sounds a little wacky, because most of the time we think of infectious, of urethritis as always being infectious. But in this case, I'd make a distinction between urethritis, which is, if I can find that, infectious, and that which is non-infectious. And the reason I would make that distinction is that keep in mind that sometimes you can have urethritis that is not related to an infection. Right? You can have, this can be this sort of scary realm of autoimmune diseases, trauma, who knows, idiopathic, which is always something you can say if you're not sure what it is and you want to sound smart. But anyway, the whole point is that there is non-infectious urethritis and there's infectious urethritis. And here's why we're going to make that distinction in a few moments, because it helps us to better understand the concept and the structure in which we're treating people. Okay, because let's try this. All right, so the infectious urethritis that we're going to have, all right, keep in mind that we can have a, I have to do that, I'll make this easy, is that we can have a STI infectious, right? A non-STI infectious, and an STI infectious. All right, so again, this non-STI infectious, it comes back to the dreaded, we talked about the anal-insertive sex. And the reason is, you can, if you assume that there's no chlamydia, no gonorrhea going on, but there's still. So the main point here is you can have a infectious non-STI urethritis, which is almost always like diverticulitis and coliform. Clean some of this up a little bit. We're going to extend this further down so it makes more sense. Okay, so now we realize that we have a non-STI urethritis, but now we're back to our old famous friend, the STI urethritis, and back to a common area that we're fairly familiar with. Let's break this down a little bit more. All right, and we have our 2 major players here that we'll take a look at. All right, it's going to be gonorrhea, if I can get gonorrhea over here apparently. Okay, I did manage to get the tablet working again, and again I now have gonorrhea, and yes, you can make all sorts of jokes about that, right? I can also have chlamydia over here. So anyway, now we're back to familiar ground, right? We've got gonorrhea, we've got chlamydia. Everyone just take a big laugh, and then we're done with that. So gonorrhea and chlamydia, and now we've got the normal treatments that we have. Now, keep in mind, we can actually make that distinction. Why? Because even though we don't have a microscope, we do have nucleic acid amplification, whatever that is, the NAAT, which is the urine test we use. And because we have that, and because our patients have waited, we can now make a distinction between gonorrhea and chlamydia. All right, so let's get these things over here. All right, and now we go to our normal sort of players, which is if we're going to treat gonorrhea, we get ceftriaxone, and chlamydia then gets treated with either azithromycin or doxycycline. So ceftriaxone, which of course I still have green, So gonorrhea is treated with ceftriaxone. Chlamydia can be treated with either doxycycline and or erythromycin. Keep in mind now that now we don't have to treat for both because we can make a clear distinction. We can make the distinction in that the patient either has, we know they have gonorrhea, or we know they have chlamydia, or they can actually have both, or neither of this. If neither, we don't treat them. So in this case, we don't have to be throwing antibiotics all over the case, all over the place. If they have a chlamydia, we simply write them for doxycycline. If they have chlamydia, we can also write them for azithromycin. If they have gonorrhea, then we give them a shot of ceftriaxone. If they have both, well, then we do both. Okay. Now, for the next video, we're going to talk about how we're actually treating gonorrhea. The reason that I'm discussing it this way is that concepts are easier this way, and then we'll layer an additional layer of complexity over the top of it. So just to close on this one, and hopefully this has not been too confusing, is that keep in mind that with our patients, because they're reliable for follow-up, and because, once I get this done over here, and because we have our friends in AAT involved, and because what will happen is our patient comes walking into our clinic, right, and we go, okay, you've got urethritis. Now we think, well, is it going to be infectious or is it going to be non-infectious? The odds of it being non-infectious are pretty unlikely, but a possibility. I wouldn't go chasing that because it's a zebra unless it becomes a giant mystery and everything else here doesn't make any sense. So instead, we're going to take our patient down the pathway of, oh, they have infectious urethritis. Now, let's say that they're practicing the dreaded anal insert of sex, and they have had the same sexual partner and were tested, and somehow we know as a fact that they have neither gonorrhea nor chlamydia. Well, in that case, it's going to be infectious urethritis. It's not going to be an STD, and the most likely thing is going to be coliform bacteria, which is equivalent to the epididymitis that we had talked about previously, which comes from a non-STD epididymitis, and remember, this is analogous to diverticulitis, because it's the same bacteria that come from the colon. Let me get rid of that. Now, let's assume that our patient actually doesn't have that, and now they come in, and we assume they have an STI urethritis. Again, we don't use microscopes. They pee in a little cup for us. We send it down to the lab, and then the lab will give us our results back, which is going to tell us either the patient has gonorrhea or chlamydia or both. If they have that, if they have gonorrhea, then we treat them with ceftriaxone. If they have chlamydia, we treat them with doxy or azithromycin, right? And if they have both gonorrhea and that, we treat them with both ceftriaxone and doxy, or ceftriaxone and azithromycin. This is a nice, easy way to think about it. I hope this makes sense. I haven't confused you. In the next video, we'll briefly talk about how to treat them if they have gonorrhea, because it becomes a little more layered. But the big point about this is how we do it in convenient care. Don't make the distinction between gonococcal and non-gonococcal urethritis. It doesn't really help you, right? Leave all these things, right? All this stuff, the microscope, the non-gonococcal, that, you leave that in the dustbin of history where it belongs, because we're not using microscopes in our convenient care.